Hey, we are back for another round table with the SCM nurses, and I'm super excited to have my favorite dentist here. Dr. Randy Smith is here out of Meridian, Idaho. And today we're talking about a super hot topic and in various sectors of health, which is sleep apnea. And I think, a lot of folks don't really pay much attention to their snoring. I mean, I know I have friends who they just sleep in different bedrooms. That's all it is, right? Just keeps you up. And I think it's one of those silent things that really creeps up and destroys people's health. And they really don't understand the damage that causes. And it's a huge driver for kidney disease because of how that impacts the heart and leads to congestive heart failure and then fluid overload and whatnot. So, Dr. Smith, this is your expertise. And I just love to have you introduce yourself and share a little bit about what drew you to this space of helping people, first of all, find out if they have sleep apnea and why should we give a hoot about it?
Yeah, so I've been a dentist since 1995, and I got drawn to the field of sleep medicine. First off, I guess because I was diagnosed with sleep apnea. And as I went down that road to treatment and caring for myself, wanted to help other people. One of the things that drives me and revs my engine, gets me excited, is when people care about their own health and they're willing to do whatever it takes to get healthy. My dad was never tested, but as I look back, I'm about certain that he had sleep apnea. He had all the signs and all the symptoms. And I wonder if that led to his early death. So anyway, that's kind of where I came from. I got excited about sleep apnea, got serious about it just as COVID was getting going. So that kind of worked out good that I was able to get a lot of training and many residencies in during that time when things were a little bit slower at the office. So it's amazing how prevalent sleep apnea is, even just sleep disorders. We had a pandemic, but we also have an epidemic of sleepy and tired people.
Yeah. Well, and I think a lot of us don't understand how much work is being done at night while we sleep. I tell people that's when the road crews come out, right? We do all the clearing away the debris and building new cells, and it's so important. Interesting that you mentioned about your dad. My dad, after my brother was killed many years ago, and my dad put on a lot of weight. And I still remember it wasn't until we caught him on video and a family video where, I mean, he would fall asleep mid-sentence and turn blue and almost convulse. It was so heartbreaking. And because of the delay in treatment, he did develop congestive heart failure. And once he was started treating for that, I'm sure that's why we had him for as long as he did. But I think a lot of people don't understand that pathway. We think of sleep disturbances or like you mentioned earlier, we were chatting before about how, we kind of get accustomed to this slow and steady decline, right? As we get older, we're supposed to get tired. Well, yes, I'm tired, but I work my tail off, right? So, yeah. I snore, but I love this one, only when I'm really tired, right? And we don't understand. So what do you think? Here at Specialty Care Management, we use a stop bang score to help us remember the questions to ask to make sure that we're screening for sleep apnea and every time we assess a patient. But what are your favorite tools, or what would you say would make you advise somebody that they should be tested for sleep apnea?
Well, so there's a number of things, and some people are probably wondering why are dentists even involved in this space? And came about in 2017. The American Dental Association came out with a statement that said that all dentists should screen all their patients for sleep apnea, just in the same way that we screen all of our patients for oral cancer, right? So as dentists, we cannot diagnose sleep apnea, but we can recognize the signs and the symptoms. And I've heard physicians say that the reason why they want dentists involved is because they know that we see a lot of patients on a regular basis, whereas many people don't go see their physician or a healthcare provider unless there's something wrong. There's too many that don't go in for their regular care. And so a couple of books I think that would be good for anybody to read. One of them is by Matthew Walker, and it's titled Why We Sleep. That'll break down, into the reasons and some of the problems associated with sleep, and that it's not just an inactive time, but like you said, that's when the work happens. That's when our memories are consolidated. That's when we heal. That's when we grow. That's when the repair takes place. So sleep is very important. The other book is by James Nestor, and it's called Breath. I think he's a journalist, and so he just went down this rabbit hole of what happens at nighttime, why do we sleep, and some of the problems associated with sleep, like sleep apnea. So a couple of, I've got a whole list of things that we look at that cause us to of questions that we ask. But even before I go there, we also need to recognize the impact that sleep apnea has. I don't have any paper that I can cite on this, but I've heard it multiple times that actually, I think it came out of the Wisconsin heart study that untreated sleep apnea will take 7 to 10 years off of a person's lifespan. And I've also heard that untreated moderate to severe sleep apnea will lead to that patient paying upwards of $200,000 in other medical bills. And anecdotally, I heard one of my mentors say that it'd be healthier for a patient to be a pack-a-day smoker than it would to have untreated sleep apnea. That's how severe it is. And so that's one of the points that we want to get across to our patients. The other factor is that it's estimated that there's about 30 million people in the US that have sleep apnea. And the bad thing is that 80% of them are undiagnosed.
Yeah.
And so again, that's where the dentists get involved. So some of the things that we're going to be looking for are first question is, do you snore? Because that's the number one risk factor for sleeping, for the sleep apnea. Other things that we look at, ask them, is if nocturia, right? Are they waking up during the night, to use the restroom? And a lot of people think that's just associated with age.
But I drink. I'm always drinking, so of course I'm going to get up to pee. Yeah.
Yeah. So the other one, in the stop bang, one of them is witnessed episodes, right? Has someone else seen you gasping for air? Do you ever wake up gasping for air? Do you wake up with morning headaches?
Or daytime fatigue, that's a big one.
Yep. Excessive daytime fatigue. Some of the other comorbidities would be someone that has GERD. In the dental world, we're looking for people that have worn teeth. Bruxism doesn't cause sleep apnea, and sleep apnea doesn't cause bruxism like it was once thought, but it's a comorbid condition that is often found paired together. People that have night sweats, If there's other risk factors, like if you're a male, you're twice the risk of a female up to the age of 50. And then after 50, basically menopause, the risk is equal.
Great. Thanks a lot. Everything falls.
Yeah.
Yeah.
So BMI, someone with a BMI over 30, they have a 70% chance of having obstructive sleep apnea. So we also look for someone that has a high arch, narrow palate, someone that has tori, the bony growths in the jawbone. Those are some other possible indicators. Something, a Mallampati score, the tongue size. If they have a scalloped tongue, those are also indicators that a patient might have sleep apnea.
Yeah, it's interesting. So when we think about this, we talked a little bit about, the impact of that in terms of our lifespan. And I think, some of those seem so far off. We talked about some of the danger signals, some of the things that we should, that we're looking for as far as clinicians in terms of these screening tools and whatnot. I think, like we were talking about earlier, I think there's a couple things that are barriers for most people. And one of those barriers is, to your point earlier, is a lot of us, because there's no immediate impact in that. I know for me, when I talk to folks, I explain that, if you're not breathing and sleeping at the same time, your heart has to pick up and do all the work that your lungs aren't doing because you're trying to sleep. And the heart as a muscle is going to grow. People get these big hearts. And then these big hearts can't do all the work anymore. And that you'll develop congestive heart failure. And someday, not today, you're going to drown in your own fluids. That's fairly graphic, but hopefully to shake them up a little bit. And I think that pathway, as we look at, what happens, that sequela of undiagnosed and untreated sleep apnea, where that heads. The other thing, besides the fact that people don't feel that immediate impact, until hopefully somebody shares with them enough to wake them up a little bit, to have them be curious enough about that. But then a lot of people, and I think Stephanie alluded to that earlier, a lot of people, they don't want to wear that jock strap on their face, right? I hear that all the time. I am not going to wear that thing on my face. And so people don't know they have so many options for treatment. And so maybe you can talk a little bit about that. First of all, in terms of, if you have some of these symptoms, how do you know for sure if you have sleep apnea? And then, what can I do about that?
Yeah, so first, if some of these symptoms sound like you, then one, talk to your primary care physician. One of the challenges, though, is that primary care physicians are just inundated and swamped. And
yeah, I got about 5 minutes with them.
Yeah, so the time with them is very short. And so then the most common way to find out for sure is a sleep test, right? It used to be, and the gold standard is still to do the polysomnogram, which is a sleep study in a lab, to where they hook you up to a whole bunch of different leads and trace your sleep through the night. But that's expensive, and it takes a long time to get in for one of those studies because limitation on the number of labs. So what has become more popular in recent years has been the home sleep test. Now, it doesn't give us all the information that a polysomnogram gives, but it gives us enough information to know if a person is positive for sleep apnea. And some of them give us extra information that's helpful also, that will even tell us what stage of sleep they're in. They'll tell us what body position they're having the episodes during. And those can be helpful also, because one of the treatments is positional therapy. we see patients that reading and looking at their study, it shows that most of their episodes are happening when they're sleeping on their back. So if we can get them on their side, or we'll find that, one side is more than the other. So even just positional therapy. But so to answer your question though, a home sleep test.
And not to interrupt, but because I have heard that before, but is positional therapy enough treatment for somebody with sleep apnea? Really?
No, by itself, no.
Okay.
But if you know that you have it, you can reduce your incidence by just even the way you're sleeping. But I do understand there's a lot of people that can't sleep on their side, whether it's because of hip or shoulder pain, and so they're on their back. But when we're on our back, gravity is taken over, and so we're fighting gravity. Yeah. So another thing too is, as a dentist, I can't diagnose sleep apnea. And so I can't help a patient other than in some counseling until I have a prescription from a physician to help them. And generally what in dentistry that we'll do, well, you think back to CPR, one of the first things you do is head tilt, chin lift. And so the device, it's a oral device that can be put in. That's essentially what it does, is it opens the airway by advancing the chin, the lower jaw. Yeah, puts you in a forward position there. But as far as being able to get a sleep test, you do need to have a physician order it. There are online services where people can go and have a telemedicine visit with a physician, and then they can order a sleep test and it can be sent to them through the mail. The patient can wear it at home in their own bed. And so I think that's one of the advantages of a home sleep test too, is I hear people that went into the lab to have it, and they said they couldn't sleep because they had all those leads attached, and then they're in a hotel bed essentially. And
you get a 4-hour read, right?
Yeah. Didn't have their own pillow. And so that's one of the beauties of the home sleep test, is it's probably more representative of a typical night.
Right.
And another advantage with the home sleep test is that it's easier to do multiple nights. And an interesting thing there is that one night might show that everything is completely normal, and the other night is when it shows up and shows that they might have moderate to severe sleep apnea, yet the first night showed nothing. So
yeah, interesting. Yeah, and I think that one of the barriers is just that, the time I've got to take to schedule it, and then I got to figure out who's going to watch the dog so I can go, blah, blah, all those barriers to that. So yeah, I know you did my sleep study. We sent that off. That was so easy to be able to do that at home. And the workup, for the one thing I like about the oral appliance is not having to, if I travel, not having to lug a big heavy CPAP, even the smaller CPAP. So because I don't check bags, doggone it.
Yeah, so we different states have different laws as far as who can even dispense a home sleep test. We can dispense it, but again, like I said, we can't diagnose it. So after the patient has brought it back, it's uploaded, and there's a board certified sleep physician that is going to score it and also diagnose off of that.
Just like test. We do for x-rays, right? You have your x-ray and that gets sent off to a doctor in Australia.
Yep.
Right?
So. Yep.
Very.
Yeah, and like you were saying about the CPAP, there's a lot of people that and I think it was Stephanie that mentioned that there's people that have the diagnosis, but then they don't follow through with treatment. And a lot of people, there's different, like Mike and Molly on that sitcom. They had a great episode about the CPAP, and others will say, I'm not going to wear that Darth Vader mask. And and others will say that they're claustrophobic. Now, I will say that the CPAP still is the gold standard of care, and if you have moderate to severe, it should be tried first. But there's, like Stephanie said, there's a lot of people that don't even want to go down that road. And so that's again where the sleep physicians are saying, okay, I know you're going to be better off if you're treated with an oral device than not be treated at all. There's a study called the SARA study to where they compared the efficacy of the CPAP versus the oral device. And what it showed was, yes, the CPAP is more efficacious. It does reduce sleep apnea better than the oral device. The problem is the compliance. And so the oral device isn't quite as efficacious, but because of the compliance, it's considered as effective as a CPAP if the CPAP isn't going to be worn all night long. Some of the other things that, some of the challenges with the CPAP, statistically, about 50% of people that were prescribed a CPAP have quit wearing it after the first year. So, and the CPAP manufacturers and the physicians know this, and and that's one of their greatest battles is overcoming the stigma of the CPAP and the challenges associated with the CPAP. The other thing that happens is people go to bed with it on, and then when they wake up to go to the bathroom, they take it off, and then it doesn't go back on. But then when you understand the stages of sleep, when we're in REM, that is when we are most at risk for having apneic episodes. And our REM sleep typically happens later into sleep, the last couple hours before we wake up. So what's happening is that they don't have the CPAP on when they're most at risk. So again, that's where an oral device, most people who have an oral device put it in and leave it in until they get up.
Yeah.
So
yeah, I think that's really important. Well, the other thing I always talk to people, I mean, you're going to be claustrophobic too when you're drowning because of congestive heart failure. So that's going to happen. But too, the masks are so different. They used to be big, and now even the full face masks are so much smaller. Or like my mom uses a CPAP, and she uses the nasal pillows, and they're pink. So come on, Lee, who doesn't like pink? Come on, little bitty things. She just loves them because they're comfortable and they just fit over her mouth or her nose. And I think that a lot of folks, gosh, try it. The DME company will make money if they get you in a mask that's comfortable. So it behooves you to tell them if you don't like the mask within 30 days, right? Most of them have like a 30-day try it and bring it back and we'll get you fitted for something different kind of thing. So I think, that diligence up front to make sure that you're, and the time that it takes to acclimate to a CPAP. So I got to say, coaching, I've done a lot of coaching for people, and yet when it was my turn, I'll just say, I was surprised at how hard it was to acclimate to a CPAP. So I wasn't ready for that. I had to take my own tablespoon of medicine. So I really appreciate the oral appliance. I know Stephanie mentioned what was the implant? Is that Inspire or something that they're talking about?
Yeah, they have one with Inspire. But I mean, I say the same thing to my patients. If one mask isn't working for you, that's not the only avenue. There's multiple things that can be done. And a lot of the times, believe it or not, a lot of them say, well, I know I have to wear it because if not, my insurance won't cover it too. So there is a big aspect of that because it's also being recorded for the insurance purposes. And they know that they need this, and in order for it to be paid, which obviously who wants to pay money and throw away money in that way. But a lot of them, I have encouraged them to perhaps speak to their physicians about the implant, which is a hypoglossal stimulator, and how that can impact their lives in other ways. I know someone personally that ended up getting it. They had severe sleep apnea, did not tolerate the CPAP, and now with the stimulator, they say their life is life changing. And they said it was very easy, simple procedure, in and out, outpatient, goes right below the skin, and they're done.
I think that's awesome to have options, but my mantra is always, once you cut, you can't uncut. So what do you think,
Yeah.
Dr. Smith? What are your thoughts on that?
Well, like what you said, there's no one doing it. Once you've cut, you've cut. So it is what we tell patients is it's what you do when everything else has failed. And so try all the reversible things first. And if the reversible things still aren't working, then you look at the surgical options, because those surgical options are non-reversible. Whether you have the Inspire put in or whether you do maxillary mandibular advancement surgery. So yeah, those work too. But the recovery for that is significant, and the cost is significant also, and they're not without complications. So yeah, we tell people, exhaust all your other resources and treatments first before you go to the surgery route. But there are, unfortunately, our society, they want a pill. They want the quick fix, and they don't want to change their lifestyle. They just want a pill to fix it. So
when you find
it's
when you find
yeah.
it, you write me a script, okay?
Yeah.
That's interesting that because they're really, for like many things, the quick fixes, being healthy, having the vitality and energy that we need to live our best lives isn't cheap. It takes a certain amount of energy to be healthy and to do the work of self-care. Yeah. And too, maybe you can share some insights on that. But when you are able to breathe and sleep at the same time, magical things happen. Like you do get rest, and you are able to have more energy during the day, which can facilitate weight loss. And I think you and I've talked about that too. I mean, the role of, and I think one of the reasons why we're seeing so many younger and younger people with sleep apnea is because the whole diabetes epidemic, or younger and younger people are struggling with this as well. But
Yeah.
what about premise if I lose 10 pounds?
Yeah, so they've done studies with that, and they've shown that if you can lose some weight, that it can I think it's a 10% weight loss.
Is it 10%
will lead to
weight or BMI?
Well, yeah, good question. Now I don't know that you asked that, but whether either or, it can lead to a 26% decrease in AHI. Whereas just the converse of that, a 10% weight gain leads to a 6 times the risk of moderate to severe sleep apnea. So yeah, the weight is a big deal, and so that's probably the number one most modifiable behavior that we have, for ourselves.
Doggone it. Well, it's just a little extra baby weight I'm carrying, Dr. Smith.
What's my excuse?
Yeah, but just let's not mention the fact that she's off in college right now. So that doesn't, doggone it.
Yeah.
Yeah.
But no,
So
you said the diabetes and the BMI, you combine type 2 diabetes with a BMI over 30, and if you are that patient, statistically, you have an 87% chance that you have obstructive sleep apnea. So yeah, you've got two strikes against you right there.
Well, so, and this speaks volumes to the people that we work with, right? Our patients are the clients that we coach. These are multi-morbid folks, and diabetes being the number one driver for kidney disease, which leads to hypertension, which of course leads to high cholesterol, and you get in this whole cycle and all of those things like what you mentioned. And then you tack on untreated sleep apnea for a long time. We see a ton of CHF, congestive heart failure, because of that pathway. And between you and me, sitting in a dialysis chair is not where I want to spend my retirement years. And so the work that we do up front to help these members become healthier is really important. Someday we're going to be partakers of our own industry, right? If we're old enough to live long enough and do well, and eventually, so if it's not us, it's going to be somebody that we care about. So it really behooves us to share this message about how simple it is to get screened. First of all, have a discussion. You don't know what you don't know. So if you're at risk, even if you don't know if you're at risk, ask, and then follow through and find a treatment that's going to work for you. I think that's really important. But knowing that diabetes is one of the comorbid conditions that takes us down this rabbit trail, this path, and we get a little heavier, and that of course increase our risk. Can I take you down another rabbit trail and talk about just the importance of oral health, dental hygiene, our dental health, and just overall health? A lot of times we're talking to folks with diabetes about this and the risk that plays also on their heart, but maybe you can share a little bit about that too. Why it's important
certainly.
to see your dentist on a regular basis.
So basically it's an inflammatory problem, right? And inflammation, I think it was the cover of Time magazine, I don't know how many years ago, but how inflammation is now the silent killer. And one of the most common things that we see are patients that have what they think is just a little bit of gingivitis. But if your gums bleed when you floss or brush your teeth, that's a sign that you have an infection. Interestingly, there's a book called Beat the Heart Attack Gene. It's written by Dr. Bradley Bale and Amy Doneen. And in it, they talk about the cats lying in the gutter, ready to spring out and get you. And one of those is oral conditions that may be asymptomatic that increase your inflammation. So whether it's periodontal disease or a tooth that has abscessed, unfortunately, most of those problems, like a tooth that's abscessed, until it's really late, most people don't have any idea that they're dealing with an abscess. If I had $1 for every time a patient has told me, well, it doesn't hurt, I'd be a rich man. Because I hear it all the time, but it doesn't hurt. So fortunately, pain is a great motivator. We just need to find other motivators before we get to the painful part. The Cleveland Heart Clinic has done studies, and I don't know how they do it, but people that have had heart attacks, they are able to get in and that blockage and take samples, and they're finding bacteria that originate in the mouth in these clots. They've also done studies of people that have blockages in their carotid arteries, and again, they're finding bacteria from the mouth. So yeah, so the what happens in the mouth, the mouth is part of the body.
It's a little
and if it's bleeding in the mouth,
yeah.
And the mouth is not sterile. And if you have gingivitis or periodontal disease on top of that, those bacteria are getting into your circulatory system.
And then if
So
you've got high sugars, there's lots of food for them to feast on, party down at your expense and
certainly.
ammo. Yeah.
Yep. Yeah.
Oh, I can't do teeth. Hats off to you. I can do blood and stool and vomitus and open abdominal cavities, but oh, yeah.
I hear that a lot.
Yeah. But I'm really glad you do. So oral health, really important to make sure that we're promoting. So if people have questions as we wrap up here, I want to make sure that nurses have a chance to ask questions. I think we've asked some of them already, but if you have them, shout them out. And then if you wouldn't mind sharing with us about, how can people contact you if they have questions or want to get to know more?
Yeah. I'll leave it to the nurses if they have any questions first.
Jane does. Oh, it's the famous saying that you're muted. There you
Yes. It was finding the little microphone. A lot of people don't clean their equipment either for
Oh.
CPAP and don't realize that that is a big risk factor for them too, to get upper respiratory or sinus infections or whatnot. I don't
Yes.
know if anybody's ever seen that happen, but
Lung infections, absolutely.
that can be that's another reason people don't want to do equipment like that. But it's got to take some stamina on your part to be able to do the right things for yourself and for your equipment to stay healthy.
My husband's religious with cleaning his, and when I use the CPAP, I'm religious with cleaning mine. And nowadays they have the ultraviolet light. What do you think of those, Dr. Smith?
Well, from what I understand, they're great. But like you mentioned, you do have to be very diligent about keeping it clean so that you don't end up with these upper respiratory infections. So yeah, definitely.
Yeah. Well, same thing with your mouthpiece.
Yes. Yes.
Yeah. Yeah. I take mine off. Don't tell my dentist. I do take mine off and I do clean it every day. So
Yeah. Yeah. And unfortunately, sleep apnea is a chronic progressive disease. It's not going to go away on its own. And so, unfortunately, if you have it, you're kind of stuck with it. And you want to do everything in your lifestyle that you can to minimize. But the treatment, you're going to have to continue with the treatment. And so you've got to maintain, whether it's the oral device or whether it's the CPAP, you've got to invest a little bit of time to maintain it so that it stays effective too.
or choose to eventually drown in your own fluids.
Yeah, that doesn't sound very good to me. So
No. I have one more question for you. What about, because you and I have talked about this before as well, but some folks, we count on the losing 10% of our body weight. Maybe we lose some weight and so we don't need that. But what about this primary or central sleep apnea? What do we do in those kinds of cases? And where do you see I know a lot of folks have a little bit of both, but can you just, as we wrap up, just share a little bit about the difference there?
yeah, so the central sleep apnea is just where the brain forgets to send the signal to the lungs to breathe. And on a sleep test, it'll show that there is no effort to breathe at all. People that have had strokes or more susceptible to this or other brainstem injuries, some heart diseases, lung diseases can lead to this also.
Or like for COPD, the retainers yeah.
Yeah, and so the only treatment that I'm aware of that they say is effective for that is the CPAP. So, but when I see that, usually it comes in what they consider mixed apnea, meaning that there's primarily obstructive sleep apnea, where there's a collapse of the airway or the tongue falling into the airspace. And so it's mixed, but most of it's obstructive sleep apnea with a few centrals thrown in there. So the concern is when it becomes that the central is the predominant. And yeah, on that, an oral device isn't going to help at all.
Okay.
So,
okay. Well, again, that's why you need the sleep study.
yes. Yeah,
Yep.
you need to know.
Yeah.
What's the old saying of
what you
what I
don't
don't
know
know can't hurt me?
Yeah, well,
It sure will.
I tell people all the time, it's like this. If I'm driving down the road with my eyes closed, it does not hurt any less if I close my eyes when I hit the tree. It still hurts. At least with our eyes wide open, we have the information we need to decide, do I want to turn right or left or stop or go, but we can make some decisions, right? So, but without knowing, you really don't have the information you need to make a decision. So, yeah. Well, thank you so much for sharing your expertise.
Thank you.
I'm very motivated now to make sure that I ask my patients, all of them, the right questions. So,
yeah, if someone wants to get a hold of me, they can call my office at 208-216-6110.
Hot dog, and his staff is all wonderful. I can vouch for him. So,
thank you.
Well, thank you very much, Dr. Smith.
Been my pleasure.
Thank you, Dr. Smith.